This chart maps developed nations by how much they spend on healthcare per person against their average life expectancy. Most countries cluster tightly here. But then there's the United States. Every year, U.S. healthcare spending exceeds $4 trillion, consuming nearly 18% of the entire national GDP. Despite this massive financial investment, American life expectancy remains lower than many of its international peers. The spending continues to climb while health outcomes stagnate. We often view a massive medical bill as an isolated event or a sign of a greedy provider. However, these individual costs are symptoms of a larger macroeconomic architecture. To understand why care is so expensive, we must look at the system's blueprint. The $4 trillion price tag is the mathematically guaranteed output of a system operating exactly as its design dictates. At its basic level, healthcare is simple. A patient needs treatment, a provider delivers it. One direct connection. But most Americans rely on private insurance. This gatekeeper negotiates prices, decides coverage, and manages billing, generating massive secondary tasks like claim processing and regulatory compliance. This administrative bloat requires an immense workforce. A significant portion of healthcare spending is redirected away from patient care into the system's machinery. The system further compensates for this complexity by maintaining the highest labor costs globally. American doctors, nurses, and specialists earn significantly more than international counterparts, adding another layer to the total expense. Every layer added between the patient and the provider multiplies the baseline cost before a single medical procedure is ever performed. The economic ecosystem also includes pharmaceutical companies and advanced technology sectors. In the U.S., pharmaceutical companies set prices with very little government regulation. Patent protections allow them to maintain high prices to cover research, development, and marketing. Most providers also operate on a fee-for-service model. This pays doctors for each individual test or procedure performed, creating a financial incentive to prioritize the quantity of treatments over the actual health outcomes for the patient. Legal risks amplify this trend. To avoid lawsuits, doctors practice defensive medicine, ordering unnecessary diagnostic tests that increase costs without improving the patient's condition. This causes cost shifting. Hospitals must treat uninsured patients, while government programs pay lower reimbursement rates. To cover losses, hospitals charge private insurers significantly higher prices. Furthermore, a lack of transparency prevents price shopping. True costs remain hidden until after care is received. These incentives actively reward overtreatment and inflated pricing, rather than medical efficiency. The final picture is one of extreme complexity. Dozens of stakeholders and thousands of conflicting price agreements create a tangled, inefficient web. Peer nations utilize universal, government-regulated systems. These models keep administrative costs low and establish firm caps on the prices of services and drugs. Tracing these tangled connections reveals a system executing the cold, precise logic of its own deliberately engineered structural blueprint. Until the fundamental architecture and its financial incentives are dismantled, the $4 trillion price tag remains a permanent, defining feature of American healthcare.